person who's responsible for that. So I think I have got the schedule up. I don't see any change to it, but one thing I want you to keep in mind that because you'll see Wednesday is not that, we don't have anything scheduled. Are we still going to Good Shepherd through next Wednesday? Mm-hmm. Okay. So you will have assignments in a group. You will be placed in groups of 3 and you will have an assigned something to do, either an activity or research. And you as a group will give a presentation on it. Your presentation, if you're doing Good Shepherd, then you'll be late in the week. It'll probably be a Friday. If you're not, you'll be on Thursday. So don't fill up your Wednesday with other things because that's time that I have set aside for you to work as a group. Okay? So that's why there's nothing on Wednesday, except for those who go to Good Shepherd. Are there any questions else about it? We only have 4 days because we got Good Shepherd and we have the Monday morning taken out with your exam. So we have 4 days to get it all done.
So we do have an exam, it's just on Monday morning.
Nutrition, what?
She was talking about ER.
You have a
So
person.
your exam is on Monday.
It'll be the next Monday.
Okay.
It's very practical. It's very basic. I think you'll enjoy it. I hope. I think you'll discover a lot about yourself. Questions about that? So just be aware that that will be coming, and you need to allow for that. Okay. Okay, EpiPen use. So what do you know about EpiPens? What do you know about them in general?
Expensive.
Okay, expensive. What?
But they have that whole skin.
Mylan increased the prices, okay. So there's been some remedies to that. There's a lot more available. There's some others that have been approved that are coming out. Places like Walgreens, Target, CVS have offered much lower prices with a coupon. So that's kind of being remedied. What else? I do not know what's going on with y'all today, but most of you are looking at your screen and smiling. So I feel like a TV. I feel like a channel that you are tuning into and tuning out of. So I don't know what you're doing. I'll just trust that it's the right thing. But it bugs me from this side. Okay, what else do you know about EpiPens?
They expire pretty quickly.
They expire. Do they really expire? What is the recommendation? Replace it every year. Why do they do that?
Maybe decrease efficacy.
So that you'll have a product that's in date and functional, okay? Because it's an emergency situation, right? Okay, so we're going to talk about out of date and what to do about that. What else?
There was some politics surrounding it, like they jacked up the prices tenfold or something.
Yeah, so when Mylan took it over, they went from, used to be $100 for a kit, then they eventually took it up to $600.
There's like baby EpiPens and then there's like adult EpiPens.
So there's EpiPens for children and there's EpiPens for adults, that's right. It's based on weight mostly. What else?
I did 2 injections for every pen. So the first one's more of an injection, and you can take the end off, and then they're like given in 2 different ways, right?
There's two per pack. And we'll talk about why that's important. The number to dispense is important. What else?
Their packaging is really nice. They all of them come with a trainer tool, which was really cool to see.
Yes, that's an important part. And we'll talk about it in the patient education, is that you need, if you are going to deal with these on a frequent basis, you need to have somebody in your group that's going to train them. Hopefully a pharmacist will do that. I won't guarantee it, but you need to have training on how to give it. Because when it happens, people have to do it quickly, they have to do it correctly, and they're nervous. Okay. So they do come with a training, and it's recommended that if they don't use them very often, at least periodically retrain yourself. Anything else?
Safer to give more than what you need than not enough.
Yes, in most situations, not always, because you can have side effects from it.
I just had a question. So whenever they did the price increase, did insurance still cover the majority of it, or did they, I'm just curious how that happened.
I don't know that. I know now they do cover most of it. So
I just didn't know if it ended up staying relatively the same for the patient or not.
Okay, so what about the price increase? What about that?
People who actually need it wouldn't be able to afford it.
Okay,
They're expensive, like before the price increase too. I'd like to add that. I didn't work at a pharmacy during the price increase, but usually people's co-pays were like 25 to 50. for
yeah,
the
so they're about
$2.
$100. They were before the prices started really going up. Okay, it's America. We live in America. We live in a market system. So people get to charge what they think is the market will bear, right? Okay, so, but the backlash had a lot, but we're also have a voice. So the backlash also led to a reduction in price or other avenues, and I'll talk about those when we go through it, okay? If you want the government to tell a group what to price their material at, then they can come and tell you. You'll make a lot of money, you have a lot of knowledge, there are people who can't pay for your knowledge, so why shouldn't you give it away? Why shouldn't you be expected to give it away for free? So if you don't want the government to tell you that, then you can't tell companies that. Because eventually it will come to bear that the market forces will force them into more compassion. Remember, governments are not compassionate. They don't give love. They are political in the way they do things, what's ever most advantageous to them. So remember where you live, and remember that that's the economy we live in, but we do have voices that can change, and it did. In the years since I taught this last, major changes have taken place in terms of availability and cost. But also companies take all the risk. They hold all the risk. And so for them to produce something and also market it costs them. I'm not defending what they did, but I want to stay in our type of market because I think it works. That's my political, that's my opinion. It doesn't mean it's right. You don't have to agree with it, but I think that is a way to look at it, is that people speaking out does have impacts on what companies do. What they did was despicable. And they've suffered for it. Okay.
So, to add on to that, though, there was something nice that kind of went along with that. There's certain coupons you can get inside and outside of the pharmacy.
Yes.
Manufacturer-specific coupons. So they may have increased their price, but they also released a ton of coupons that allow for everyone to get their first package free. So that doesn't affect the rest of them, but as long as you know your resources, it's possible to find coupons that'll help those patients in need to get 1 or 2 packages.
That's true. And there's another group that's come out that now has a patient assistance. So for anybody who makes under $100,000, which is fairly liberal compared to most patient assistance. And you're right, there's a lot of good coupons out there. And Walgreens has a price of about $100 for 2 if you have no other means. Other places, there's no copay if you have insurance. So there's all kinds of varieties of ways to get the drug into the hands of people. Other comments? You can disagree with me. It has nothing to do with class, but that's my opinion.
How long has the EpiPen been out?
Oh, long time.
Okay.
Oh,
So
gosh, I don't
they
know.
must have been able to corner the market. It's why they just were able to raise the prices. I'm just curious, since it's been out so long, why is there no alternative or generic?
There are now. Well, because you have a limited market. So a lot of people are not going to go into it because they're not going to reap anything to offset their cost.
Gotcha.
So I think it's that more. What?
Didn't they also patent the device, so it's not that they patented epinephrine, it's just they have that specific
The
device
auto
for
injector is their device. Now, other groups have come out with their own devices, so that's another part of it, is the patent on that. And all the insulin pens do the same thing. They patent a device, they patent the drug. So that's true. So the delivery system's patented. Yes. Other? Okay. Let's talk about EpiPens then. I'm using it as a generic. You know, it's like Kleenex is a brand, but now we just use it for, I need a tissue, I need Kleenex. So I'm just going to I'll use that interchangeably. So the drug of choice for treatment of anaphylaxis. In terms of its pharmacology, it's a sympathomimetic, so it's an alpha agonist and a beta-2 agonist. So it helps to combat mediates the vasoconstriction, the increase in peripheral vascular resistance, decreases mucosal edema. The beta-2 is going to cause bronchodilation, that should sound familiar, decreased mediator releases from mast cells and basophils. So when injected properly, most of the time there's very little adverse effect. You can get some transient, they're listed there. Those should be predictable based on what you know about those drugs now. So the palpations, you got beta-1 effect. Anxiety, restlessness, headache, but those are usually minor and most patients have no symptoms at all. The other would be just from the injection itself. So it takes a pretty good amount of force slight force to put it in and hold it there. It has some recoil to it with the injection. So there could be some injection-related small injuries. No absolute contraindications. The only would be to be careful with older patients who have myocardial ischemia. Might be at higher risk, but it is not a contraindication, nor is pregnancy. So here is the list of, I'll do that later. So this is not a complete list. There are more drugs than this. Sophie pointed out there are strengths for children, strengths for adults, okay? Based on weight usually. There are authorized generics now of EpiPen that are out. There's another one called Auvi-Q, which must be a new one. I hadn't come across it before. This one is one that if you have commercial insurance, your copay is $0. And this is the one that also has a patient assistance up to $100,000 for patients to apply for. But they have to be uninsured by any means. Let's see. And there's the Walgreens prices. This is what I found last night in terms of money with a coupon. The other is that in June there was another pre-filled, so this is a pre-filled syringe, so it's not an auto-injector, that was approved by the FDA. Not sure how to pronounce their brand name, Simjepi. I don't think it's out yet on the market, but it's been approved. So this one is much more affordable. Now, Inspired auto-injectors. So they also published a study looking at in auto-injectors that had been at least 4 years out of date. So the recommendation is replace your EpiPen every year. Well, that gets expensive, especially if you haven't used it. So remember, with out of date, when there's an expiration date put on there, that is due to a specific calculation of a drug that is stored under certain conditions, temperature, humidity, and they look at the rate of decay. So the expiration occurs when 90% of the active drug remains. So when the drug has lost 10% of its effect is when expiration dates are labeled. Okay? If patients don't store their drugs appropriately, they'll degrade faster. So heat usually is a big degrader. Freezing something often will degrade things quicker, especially when it thaws. But when a drug is expired, if it's been held under all the right conditions, it still has a lot of active drug. You know this if you've held on to drugs. They still work, even years after they've expired. This is never to promote the use of out-of-date drugs. But in this situation, what they are saying is that it is better to inject an out-of-date drug than inject no drug at all. Okay? So they wanted people to feel comfortable that if it happened, you haven't replaced it, and you need it, inject it, because you'll still have active drug in there. Okay. Okay. Let's look at some pictures. So there's the EpiPen. There's a 2-pack. As Lauren said, I think of every one I looked at, they're always going to be dispensed as a 2-pack. Okay. And we'll talk about how you use those. So you see the auto injector there. They did a nice job in that they put the directions right on the device, which is a little bit unusual. This is what, a year ago, this is what a lot of people were doing, and I still see a lot of things on the internet about teaching patients how to, or even office nurses, how to draw up and dispense EpiPens, or teach patients how to do it. So I have a lot of problems with this. These are my opinions. I'll tell you the good and the bad of it. So if they're using glass ampules, so you can get epinephrine in an ampule or you can get it in a vial. With glass ampules, you see on the, let's see. Ampules are made so that there's usually a band of weakness. So when you pop those, they'll usually break cleanly at that line, which on this one is pretty prominent. But you never want to withdraw those contents by just a usual needle. You have to use a filtered needle because glass shards get down in there. So that's my problem in people giving patients ampules or drawing it up themselves. I don't know what they're doing. But here's a filtered needle. There's the filter right there. So if I was going to draw it up as a pharmacist, I would draw it up with a filter needle and put it in a solution or a bag. The other thing is that when you start drawing them up and handing them out to patients, you don't know what the adherence of that drug is to the syringe that they're using. So some drugs adhere very strongly to plastic. Insulin's one of them. And you don't know how they're going to store it. So I am just very anti this. I understand why people do it, they do. Because this cost is less than $10 and is affordable. But I have a lot of problems if it's done this way. That's my opinion. Here is another doctor who has a blog, and he also recommends giving patients ampules and having them draw it up in a situation. I have a lot of problems with that too, in terms of patient's technique. Just drawing it up right, getting the right dose, because that vial has more in it than they're going to inject. So I get it, I see, and then he puts it in an Altoids, a tin. To me, it's just so offensive as a pharmacist, I can't tell you. But I get it. I do understand why people do it, but I have grave misgivings about doing it. I would never promote it to you as a way to solve the problem. I think that going through the other market forces are the way to go. But I'll open it up. I've been very strong in my opinion. Anybody have a different opinion? Or worked in a doctor's office that did this?
Doctor mentioned it just because patients were asking about the price increase and stuff, but I don't think we ever ordered Epi for anyone. I also would think about, like, now you have a Sharps-ish situation where with the EpiPen you don't have to, which is a huge deal, but it's just another thing that the patient has to deal with.
Yep. So this is what a lot of the blogs out there are promoting. And there's a lot of physicians and healthcare providers on those blogs that are telling patients how to do it. So that information's out there. Okay. So this is the one I told you that's just been released or approved, is this Symjepi. So a little bit different device. I'm not quite sure how to work it. I think that it also has directions on, I see a 3 on the plunger, so it must have a place for each step marked. Oops. So that's what that one looks like. Questions or comments?
I was just going to say, the other thing, my nephew, he has to have an EpiPen with him at all times. So if he is dropped off at daycare, all those different things, the instructions on the EpiPen is super nice for like a comfort factor for his mom, knowing that somebody could administer it if needed and she wasn't there.
Okay,
So
you raise a really good point.
huge.
Yeah, we're going to talk about that too. What do you do in this situation? Okay, so the number of auto-injectors to dispense. Some of it will depend on where you're located. So the World Health Organization has this guideline, I think it's a good one to keep in mind. There should be one dose available for every 10 to 20 minutes of travel time from a medical emergency center. So the recommendation, if somebody has to have who uses an EpiPen, they should be medically followed up. So that's why they're using that distance. Weight will also come into bear, so very large individuals may need multiple injections for them as well. So keep that in mind when you are writing the prescription. So they're available in a 0.15 and a 0.3 milligram. The higher the dose is for adults and for kids who weigh more than 55 pounds. Now the only thing I read with that Symjepi is that their break point is 66 pounds, which causes a little bit more confusion, I think, when we're going to different. Large obese adults may need more than one, so they can give more. You can give them not back to back, but about 10 minutes apart, if needed. Let's see. Children. Mostly, I want you to know that there is the dose is based on weight, and that the break point is usually in that 55 to 66 pounds, and the dose is 0.15 and 0.3. Small children, then you're going to use that 0.15. Key teaching points. So this is the things you would need to cover, or someone in your group practice would need to cover with folks. One is to get a point that anaphylaxis is very unpredictable. Patients can do the very same thing and have different reactions. They can have mild one time and have anaphylaxis the next for no explained reason. So going over that with them is that their reaction will not be the same every time. Epinephrine is the best treatment. So antihistamines will help, but they will not counteract the respiratory effect. So they can't prevent death like epinephrine can. They also need to carry it with them at all times, which means at all times. So the thing to kind of raise with patients is they'll have certain places they go all the time and they'll carry it with them. But then they'll have times where they get out of a routine. So having people think about that, plan about it, rehearse about it. I'm amazed at when patients go on vacation and they'll tell me, I forgot all my meds. It's like, how could you forget? You do that every day. Well, it's not the usual. So it's the unusual that usually tend to get people. So having them think through that. Think about how remote you are. If you're going to go on a camping trip and you're going to be an hour from a medical facility, take that into account. We talked about antihistamines, asthma inhalers, not enough. When to use it? It is better to err on the side of using it when you don't need it than to not use it when you need it. So you can't overuse. So immediately, if there's trouble breathing, tightness in throat, lightheaded, think they might pass out. If a child is not responding is normal, if they've eaten or been exposed to a food or something that usually brings about that. If they experience vomiting after eating, flushing, hives that appear quickly, then using the EpiPen or the epinephrine. Coughing, so something that would give you a clue that there is respiratory distress or bronchoconstriction. So we talked about food trigger, previous anaphylaxis, widespread hives without known cause. So sometimes they'll know they ate a cookie and found out it had peanuts in it, or they looked at the label, oh no, my goodness, it's made in a facility where peanuts are processed. Something along that line. How to use? IM is better than sub-Q. The device is constructed to develop an IM. If patients don't push it in all the way, they may give it sub-Q. That still works, but IM is best. So teaching patients, since kids are wiggly or may not want that needle in their leg, holding the leg firmly and putting it in up to the hub of the needle is important. Let's see what else. Holding the device in place for at least 3 seconds, 3 to 5 seconds would be good. Most of the drug is delivered immediately, but keeping it in mind, remember we talked about insulin, if you inject it and then pull out the needle quickly, insulin will come right back up that track and leave a little bubble of fluid. So you want to have at least enough time that that medicine will settle into the space. It'll do it quickly, but if you pull it right back out, the medicine may come right back out that track that you have created. You don't have to undress. It is designed to go through clothing or material. Anybody ever used one or had to use one on someone? I meant to ask if anybody had experience with one. Okay. Using without delay. That's to continue to stress that. If a reaction should occur, administer the epinephrine first, then call 911. And if they are transported, using it en route is also important instead of waiting. Going to the emergency room because the exposure may be initially handled, but they may redevelop symptoms. So that's why we want them to go and be evaluated. If they get to be lightheaded, making sure we can keep perfusion to the core of the body is important. So talking to patients about elevating legs and keeping them well cardiovascular intact. Warning patients not to sit somebody up with anaphylaxis. You know, if you can't breathe, that's a normal thing, is to want to sit somebody up. But that can cause what's termed an empty ventricle syndrome, where they suddenly get a loss of return, and so they lose consciousness and can die. So keeping them in a supine position. On the next page, more than one dose may be needed. So giving them every 5 to 15 minutes as their symptoms warrant. The training device, Dylan's told you that those come in the package, and so reminding people to practice and to be ready. And the other is teaching others. So Lindsay brought this up. So you have to think about who's in your sphere. So you want other family members to recognize that. You want teachers or anyone else, co-workers, anyone that might be spending a lot of time with them, also knowing how to do it. So in the church that I go to, in the small group that I'm in, one of the families has a child that has a severe peanut allergy. So when we first started meeting in a small group, we were all warned, and we do a lot of potluck and food. I don't know, Bible and food seem to go together a lot, so people we're always eating together. So we're always warned, nothing with peanuts, nothing that's in a facility where peanuts are made. And every time we have food, the mother always goes around, are the peanuts in this, are the peanuts in this, are the peanuts in this? So she's very good, and she's got us trained. So we all know what to do, how to recognize it, and where they keep the EpiPen. So doing something like that, like with I'm sure daycare workers, surely they're trained, or parents need to train or make sure that they know how to use. Storage, since they are going to be carrying it with them all the time, storage is important. Keeping it with you is better than leaving it in your car where the cold or the heat could get it. So that constant change in temperature will accelerate the breakdown of that drug. So having the patient keep it with them, which we prefer, is best. Other instructions about other circumstances, again, if they're having mild symptoms and they're very remote, treat. If they're mild but they're progressing rapidly, treat. If they're uncertain about the severity of the reaction, treat. And if they've had a known ingestion of food or an insect sting, then treat. Questions about those? Any comments? Okay. Vasopressor and inotropes. Okay, so have you talked about septic shock? Have you had any of the shock? Yes, okay. Did you talk about medications, treatment?
Just for ACLS stuff.
Ah, okay. So was that Dan? Did he go over pharmacology and, so maybe this is repeat.
We just did it briefly yesterday, it was like a 15 slide show.
Okay, let's do this. Let me have you look at the very back, page 8. The thing with inotropes and vasopressors is that you need to go back and think about where are alpha receptors, what happens when we stimulate it or block them. Where are beta-1 receptors, what happens when they're stimulated or we block them. And where are beta-2 receptors, what happens when we stimulate or block them. Okay? This is a really good table. And it shows you each of the inotropes are at the top, the vasopressors are at the bottom. And it walks you through what happens, what do they do to alpha-1 receptors, what do they do to beta-1 receptors, what do they do to beta-2 receptors. The little plus marks, the more there are, the more potent the effect. If it has a little negative, that means there's no effect. You'll notice also at the very end, it has their VD for vasodilation effect, VC for their vasoconstrictor effect, INT for their inotrope or their effect on contractility, and last is rate or their chronicity, chronotropic effect. I would spend a lot of time with this chart, thinking through it and going back over the material that we're going to talk about for the next half hour. Okay? You'll note on some of them that there are changes based on the dose. That's what makes this so hard, is that it's very dose dependent as to what receptors you're affecting and how much effect you are getting. It's hard. It's hard for me because I don't deal with them all the time. I really have to go back and think through it. Okay? So thinking through, what does the receptor do? What happens when I stimulate it? What happens when I escalate dosing? What will happen to cardiac output? Usually we're trying to maintain cardiac output and perfusion. Okay? So we're either trying to keep their blood pressure up, or we're trying to keep it down so we can perfuse, trying to keep the kidneys alive and the heart going. Okay? So you'll see one of those drugs only has, in very low doses, all we affect is the renal bed for dopamine. Okay? That's how you need to think through it. And then you'll eventually be in situations where you will learn. And you have to watch the patient. You have to do a lot of cardiac monitoring when you are using these drugs. Okay. Let's go back then to page 5. So alpha adrenergics, where are they? Vascular wall. Okay. So when we stimulate them, we usually are trying to get vasoconstriction. So we've got a shock situation, hypotension. These are the drugs we're going to want to use. Beta adrenergic, beta-1s in the heart. Inotropic, stimulate contraction of the heart. Maintain cardiac output. Entropy, chronotropic for rate, keeping the heart going. And then the beta-2s, peripheral vasodilation. So if we have vasoconstriction, shock, often the periphery shuts down in order to keep the core going. Sometimes we need a vasodilator. Dopamine receptors are the oddballs because they're in all different beds, and how we affect them is very dose dependent. So you'll see they're in the renal, they're splanchnic, the coronary and cerebral vascular beds. Stimulate it, we get vasodilation. So if the kidneys are shutting down and we want them to work, we can use low doses of the dopamine. These hemodynamic values, I'm assuming, are familiar to you. Not necessarily going to test you on them directly, but you ought to be conversant with them, because often how we monitor these drugs is based on these parameters. So you know cardiac output, you know mean arterial pressure, it's the diastolic plus systolic divided by 3. Normal value you should have some idea about. I can test you over those. If I did, I'd give you the normal, 80 to 100. Systemic vascular resistance. So those determinants are there at the bottom in normal values. Let's see, central venous pressure. Most of these drugs we're going to give through a central line. We're not going to do them peripherally. We'll give them centrally. Measuring the pressure in the right atrium, determined by preload. There's your normal values, and there's usually the goal of treatment. Okay, so those are familiar to you, at least you've heard them before? Yes? Okay. Classifications of shock, did you use these 3, hypovolemic, cardiogenic, and septic? Okay. So hypovolemic is related to intravascular volume. Cardiogenic, abnormality of the heart, can't maintain cardiac output. Distributive shock is usually due to septic shock. You've got a change in vascular tone, or you've got lots of vasodilation and fluid moving out of vascular space. Clinical findings are listed there for you. These you should be familiar with. Low blood pressure, increased heart rate, tachypneic. You ought to be able to think through why those things happen as well. Mental confusion, if you can't perfuse the brain, then it's not going to work well. Cutaneous vasoconstriction, we're shutting down everything to maintain core organs. Oliguria, we're also going to shut down the kidneys in order to keep vascular volume up. Elevated lactic acid is going to come because in some tissues we're going to switch to anaerobic metabolism, so we're going to get an increase in lactic acidosis. So that will contribute to a metabolic acidosis. And then oxygen saturation is going to be important. So goals of therapy. Let's look under hypovolemic. We want to maintain tissue perfusion. Cardiogenic, we want to maintain their mean arterial pressure and their cardiac index. So we're going to optimize preload because that's going to keep blood returning to the heart, and then we can pump blood also out up to the brain. And we're going to reduce afterload to take the work off the heart, to also decrease myocardial oxygen demand. In septic shock, you got to get rid of the infection. Got to get rid of the toxins, endotoxins that are being produced that are causing the vasodilation. Okay, next page. Okay, so under treatment, again, cause is important. If we're dealing with hypovolemic shock, you have to correct volume before you do most anything else. Okay. So if they've lost volume, if they've lost blood, replace the blood. If their volume is low, if they're hypotensive, then you're going to use either crystalloid solutions or colloid solutions. So crystalloids would be your normal saline, your Ringer's lactate. So those are going to be volume expanders, right? Your colloids are like hetastarch. Those are very oncotic pressure solutions, and they're going to draw fluid in. Most of the time you're going to use the crystalloid. Those are going to be your most common, would be a normal saline. Because it's going to stay in the vascular space and not go out, which is what you want it to do. So let's start with inotropic agents. The inotropic agents are dopamine, dobutamine, and then on the next page, epinephrine. So let's look at dobutamine. Look at that last chart. So dobutamine has a wide dosing range. That's good, so we can titrate it to effect. So it is primarily a beta-1. So if it's a beta-1, what's it going to do? It's going to increase heart rate. It will also increase contractility. It's low alpha-1, and it's low beta-2. So the predominant effect comes from its beta 1. So if you look over, you get some vasodilation, you get no vasoconstrictor. You get inotropic effects, are really good. If you need to increase cardiac output, it's good, but it's not hard on rate. So it doesn't consume a lot of oxygen demand, doesn't increase that. So if ischemia is a problem, it's not going to worsen that as much. Okay? Let's go back over to the page, on page 6. So it has inotropic, chronotropic, vasoactive properties. And it is highly variable, depends on where you are in the dosage range. It's usually a second alternative to norepinephrine if you need a vasoconstrictor. Let's see. If you look at the very last sentence, it's preferred in patients who have a depressed cardiac output, normal or elevated pulmonary capillary wedge pressure, or moderate to severe hypotension. So it will maintain cardiac output and keep their blood pressure normalized. Questions about that one? Sorry, I did dobutamine and then went over and did dopamine. Sorry. Didn't mean to confuse. Let's go back to dopamine since we just went through that. Dopamine, again, that's the one that has all the different dosing ranges. I apologize. You see at the very lowest, it's renal. So you have no effects on alpha or beta receptors at very low concentrations. As you increase, your beta 1s start to be the first ones that then become active. As you increase the dose, you see that increase in beta 1 activity. And at the very highest doses, you're going to get alpha. So if you go over and look at it, you see that the vasoconstrictive action is highest when you are at the highest doses and lowest at your lower doses. Inotropic activity stays pretty consistent across the dosing range. And rate picks up only as you get up into the higher range. And vasodilator, it doesn't have as much effect. Okay, sorry about that. So that's dopamine. Dobutamine, let's go back to dobutamine. So dobutamine, potent inotropic agent. So if you flip back over there to the page, you see where it's a 3+ under inotropic. Primarily beta 1. Not a vasopressor, doesn't have that much activity out on the alpha 1s, but it does cause vasodilation. So that's a little bit unusual. You've got a good force of contraction in keeping the blood pressure normalized. Let's see, increases force of contraction rate, reduces left ventricular filling pressure. So that's good because you've taken afterload off. Minimal alpha and beta 2, you get overall vasodilation, but you don't get a lot of compensatory reflex that is going to then offset your actions. So that's good. That's a good effect. Most frequently used in refractory heart failure and cardiogenic shock. Mostly what I'm going to focus on is the pharmacology. I'm not going to focus on the use of the drug because I'm not spending that time on it. Okay, epinephrine. Okay, look at the chart with epinephrine. Again, you've got some differences based on rate. So you see at low dose, it's predominantly beta 1 and beta 2. So inotropic effects are high at the lower end with some chronotropic effect because you've got that beta 1. At the higher doses, the alpha then becomes more predominant. So vasoconstriction would become more, and you see that with the 3+ under the VC column. All right, so let's go back to epinephrine on page 7. Again, dose-dependent effects, potent beta-1, moderate beta-2, and alpha-1. At low doses, you increase cardiac output. And the alpha adrenergic receptor stimulation at higher doses is what gives you that vasoconstriction, but you've got beta-2s that are also balancing that. So your effects on blood pressure overall is pretty even. Except at the higher doses, and that's when alpha will predominate. So then you could get a vasoconstriction. Pretty much treatment of anaphylaxis, you know that. Second line agent in septic shock, management of hypotension after coronary artery bypass. You're not going to see it as often as you will see norepinephrine used. Okay, vasopressors. So the vasopressors we're going to look at are norepinephrine predominantly and phenylephrine. I put vasopressin on there, but I didn't include it in the discussion as much. Okay, so let's look at norepinephrine. Again, very wide range of dosing. Pretty much predominant alpha-1, so you see 5 pluses there. Okay. So when you look over, you should start to be able to predict you're going to get vasoconstriction. To almost that's exclusive. Has some beta-1 activity, so you see some increase in heart rate and force of contraction, which shows up as 1 plus in the last 2 columns. Everybody follow that? Okay. So norepinephrine is really your vasopressor of choice. It's the most common one used. Get some increase in cardiac output, increase in mean arterial pressure, preferred vasopressor in septic shock, so keep that in mind. Vasoconstricts at all infusion rates. Heart rate and cardiac output remain fairly constant. So vasopressor of choice. Phenylephrine, go over back to the chart. It is alpha only. It also has a fairly wide range of dosing, so titration is easy. And it's for vasoconstrictor. It'll be a second line to norepinephrine. Then vasopressin doesn't work on the alpha or betas. It's a direct vasoconstrictor, often used in septic shock as an alternative. Okay, so focus on what the drugs do. So if I quiz you, it would be over their alpha-beta effects or their vasodilator, vasoconstrictor, inotropy, or chronotropy. Okay? Does this help or hurt?
Does vasopressin, you say it acts on the alpha receptor?
Vasopressin is a direct actor. It's a direct
Okay,
on the
okay.
vasculature.
Right.
Okay, complications, last page. So hyperperfusion, if you've got too much vasoconstrictor activity, then that would be a result that should follow. Other would be decrease in perfusion, so different beds could suffer from that. Dysrhythmias, sinus tach is going to be common because you've got chronotropic effects with most of these drugs. AFib as a potential toxicity, and then also ventricular arrhythmias can occur. Myocardial ischemia, I have seen people have heart attacks due to secondary to epinephrine infusions. So that in your more vulnerable populations is a possibility. Local effects, these are terrible if they extravasate. So if they move out of the vein, they can cause a lot of damage, especially with vasoconstriction. That's why we put them through a central line. And then hyperglycemia, because you're blocking the release of insulin, then blood sugars can go up. Flip back to page 7, just tachyphylaxis can occur to any of these. So they're usually short duration. You're usually trying to get somebody stabilized and moving them on to something else. So these are not usually things that are kept on for long periods of time. They can be for days, but usually we're trying to move and correct the underlying problem in order to get them stable and off of these medications. Questions? Okay, I will see you next week then, the end of Monday, I guess, Monday afternoon.
Oh, yeah, all these ones. I think I got that one right, but only as a free trip, yes.